And he's the professor of surgery, so obviously he's very good looking, at Barbara and Donald Zucker School of Medicine at Hofstra, Northwell. Mitch did his undergraduate studies at the University of Pennsylvania and attended medical school at New York University, surgical residency at the Maimonides Medical Center, became chief of bariatric surgery at Lenox Hill in 2000, so there's some experience for you. He's lectured throughout the world and is well known for his work. In fact, Mitch has lectured for us on webinar style already. And he's well known for his work on pyloric preservation, the potential importance of glycemic variability in bariatric procedures. He holds patents in the area and has published extensively. He's performed surgery in many international countries, Spain, Italy, Turkey, Israel, Bahrain, Saudi Arabia, Kuwait, UAE, and Mexico. Please join me in welcoming Mitch to the podium. All yours, Mitch. Thank you.
Thank you. Thank you for that wonderful introduction. And I can't tell you how honored I am to be here. And I think listening to Henrietta and Jeff speak about the traditionalism explains why Australia is such a special place. And as a boy from Brooklyn, where we really didn't pronounce words too well, although I still don't understand where the R is in cans. But like when people said Maimonides, it used to be Maimonides, and you know, where I came from, if you watched any movies, the word F-U-C-K could be a noun, verb, adjective, or just a whole sentence. But it's been a marvelous type of ride, and what I really like to do today is just tell you a story, kind of the story of my career and how my vantage point has changed, and how I think we can helpfully tell a better story so that more people can be treated and look differently at the disease we treat. Just my disclosures, I don't think anything will be relevant, and I just like to start with a quick video. It's interesting. How can I get this to play?
Oh, it should play. Evan will make sure it plays.
Evan will make sure it will play. And this video was recorded in 1997. And the point that I'd like to make is this story could be told today. And despite telling this story in 1997, 1998, and for 23 years, we're still talking about the same things.
For people who suffer extreme obesity. Now doctors are finding that surgery to lose weight brings additional health benefits. Here's Dr. Max Gomez with details. Max?
Well, Sue, one life-threatening problem that most seriously obese people suffer from is diabetes, usually type 2 diabetes. But that's relatively rare in adolescents, even if they are morbidly overweight. This is the story of a Brooklyn teenager who was in that predicament, underwent surgery, and it cured his diabetes.
304, terrific.
At 6 feet tall, it's pretty clear that Robert Bush is a very large young man, but he used to be larger. Until very recently, Robert tipped the scales at 475 pounds. It's caused the 17-year-old a number of health problems.
I woke up like I was tired. He was like choking in his sleep. Yeah. But sometimes you had to like shake him to make sure.
Yeah, he was still breathing when he was asleep.
So he used to make so much noise like in his chest, sound like a big rattling and everything.
Robert's weight was also causing him some hip problems, but of more concern was his high blood pressure and especially the type 2 diabetes he had developed.
Clearly, patients with diabetes have a whole host of problems associated from loss of limb to loss of kidney function to heart disease, rises in bad cholesterol, decreases in the good cholesterol. And clearly, Robert was already showing many of these conditions, which ultimately would have led to him having an untimely death.
When all conventional attempts at weight loss failed with Robert, he and his family decided on surgery. It's a relatively new approach that both reduces stomach size and partially bypasses several feet of small intestine. It keeps Robert from eating very much and also keeps him from absorbing all the food he does eat. But most amazingly, the surgery has eliminated Robert's diabetes.
He's taking no insulin as the weights come down. His blood sugars have remained in the normal level. He's already back at school and doing quite well.
Rather than this dying when I was a little older. So it made it all worth it.
Yeah.
So
Now we checked on Robert's progress today, and surprisingly, he hasn't lost a huge amount of weight.
In recent years, surgery.
So, you know, again, I wanted to start with that because it's interesting. You know, when I began my career, I thought that if we had videos like this, we cured diabetes. people would hear the message, hear the outcome, and access to care and care would change it. Years later, I realized what we were missing. What the public sees in this message and what people see is that weight loss works, that eating differently works. And what we still haven't answered, whether it's medications or surgery, is why people need an operation or why they need treatment and medications to answer that question. And I think that, that's really what I wanted to do today, because I think it begins to explain why our message has not been heard, because what people see in this video and what we see are two different things. I think COVID gave us a real good chance to look differently at the world. In March 2020, all of our lives came to a stop, especially in New York. New York was overrun with COVID, happened very quickly. Tom Hanks came to Australia, as a matter of fact. The NBA stopped on the same night, and within a week, my whole hospital in New York City was in ICU. Elective surgery gets shut down. And the reality that we saw very early is that the people who were dying came from nursing homes, except for one group that was obese, diabetic. And basically what we were able to see is that there was a phase change. So if the average age of somebody who died was 75 to 80, the average age of our obese patients was 60 to 65. And it made me begin to look differently at obesity as kind of accelerated aging. And, I'd go to meetings and we talk about how certain cancers are increased, or how when you see cataracts in young people, it's increased. And came to the conclusion that what really obesity and metabolic syndrome do is they accelerate your aging process and result in a phase change, so that physiologically you're about 10 to 15 years older than what you really are. And it made us look back at some of the things we were doing to see how we can begin to explain that. And then in context, if you begin to explain obesity as accelerated aging, you kind of make it relevant to everybody and explain why treatment is so necessary to do so. So when I grew up in Brooklyn, New York, and I know everybody where we turned the corner and ran home and really never pronounced any of our words, kind of thought of obesity as almost like accounting, that you had a dietary ledger, intake, outtake. You would see calories, so this has that much, and we concentrated on how many calories are what we ate. And in that way, we're all the same. Whether I eat a pizza or you eat a pizza, on the outside, it's exactly the same. But on the inside, what happens is probably completely different. And just like our message has been the same, people remain confused about what to eat. Is carbs good or carbs bad? Low-fat diet, high-fat diet. Butter, we went from avoiding butter to butter being back in style, and bread being bad. And what our public has seen is a lot of confusion. And why is all of nutritional science, and I'm sure we have a lot of nutritionists in the room, so difficult? And that's because the background is different. What we do on the inside is so different, how we process fuels, and that kind of limits virtually every study that we do. But deep down, we know we're not an accounting ledger because we know we can't disappear. Everybody in this room knows that what you used to be able to eat when you were younger is different. Every menopausal woman that comes into my office said, I'm not eating any differently, but I've gained 20 to 30 pounds, and it's all in the center of obesity. And I think it all comes to a very similar point in some of the things that we can discuss. So, a few weeks ago, I saw, a highly successful lawyer who gave up her career to raise her kids. Her husband was president of one of the investment banks that everybody knows about, hired a private chef, personal trainer, has done everything possible to lose weight, and looked at me and said, I've already spoke to the CEO, you're operating on me Monday morning. And I did, it's because you know who you work for. And the question that everybody has, and the questions that my dietitian have, and the question that people have is, could this possibly be true? And my answer is somewhat nuanced. The answer is, it is true at this point in time. I do believe she's working out every single day. I do believe she's changed her diet. But what I do believe also has happened is kind of a metabolic switch has been turned on that has changed her from being somebody who will oxidize fat to somebody who only stores fat. where we originally were talking about the Aborigines, and we can, as I go through, I can give you the evolutionary information about that, and I think that that's what's been lost, and we began to look at that. So what has been the common treatment of obesity is kind of lower your intake, but be more active. But the problem is, if your metabolic switch is converted on in a certain way, what happens is when you become more active, you have to go to the bank and eat and get more fuel. So if you're not oxidizing fat and you're only oxidizing glycogen when you're active, what do you have to do? You have to replenish the glycogen. And we all know that glycogen is water soluble, so we only have 1,500 grams of glycogen in the body, and if we stored energy in glucose, we'd weigh 1,500 pounds. So we store energy in fat, and what happens is our patients don't have access to their fat. So what happens when we tell them to slow their intake is they get adaptive thermogenesis, and this is one of the problems why we're going to have a lot of conversations about what to do after the sleeve, is that our patients react against weight loss. So what do we tell them? Do high-intensity training. The more you train, the harder you train, but we never look at what fuel they're burning, and we began to look at this almost by accident. So what I began to do is back up, along with our dietitians and our research residents, and began to look at these things very differently. And we almost found this by accident, and we began to learn a lot about exercise physiology. And you find that the best analogy that I can give you is that human beings are like hybrid cars. So what does a hybrid do when it's, at low power, it's using electric, and then it shifts over to gasoline? So when you're sitting in this room, listen to me pontificate, and kind of say whatever I'm going to say, you really should be burning fat. And the healthier you are, when you begin to exercise, the longer your zone 2, the type where your muscles are predominantly burning fat, and then towards the end of your exercise routine, or as it becomes more intense and you begin to build up lactic acid, you then should convert to burning your glycogen stores. What we have found is that our patients, even at rest, are significantly oxidizing glucose. And one thing to really keep in mind is that mitochondria are the only thing that can oxidize fat. So mitochondria are absolutely fascinating, but mostly in muscle. And it's kind of interesting when you look about things is that the cells that have the most mitochondria, like muscles, cardiac muscle, also don't have high cancer rates. And I'll bring that back later in the time. And mitochondria do something that's really, really, really fascinating, is they turn chemical energy into electrical energy back to chemical energy for us to do our things. And mitochondria, you inherit your mitochondria from your mom. Mitochondria have their own DNA. It's one of the explanations for why females live longer than male. There are several different explanations for that. One is that there are harmful things on the Y chromosome. I think a lot of people would vote for that one. Another is that you only have one X chromosome that's active, so if something's severe, the second X chromosome can take over. And the third is that since mitochondria have DNA, there's a mismatch in men, because the DNA of mitochondria only comes from females. So mitochondria can only oxidize fat, and what should happen is you should be metabolically flexible, or partition your fuels, so that you can have an orderly sequence of going from glucose when it's necessary, or fat when it's necessary, fatty acids in the muscle, to burning glucose. And what happens when people are obese is there's an accumulation of fat inside the cell. And you can think of it almost like there's a traffic jam in Sydney going to work. And instead of having an organized sequence through the mitochondria get blocked, and the other parts of the cell, like the cytosol, that can oxidize glucose will go ahead and oxidize glucose. So what I will tell you is that at a very early juncture, obese people basically go immediately to high-octane fuel. Harvey Sugarman, let him rest in peace, used to try to explain obesity as being a disease of abdominal hypertension, so that the increased pressure in the abdomen makes the heart beat harder, makes the lungs work harder, makes it harder to bring back blood from your legs against gravity, which is why you burn more calories running or bicycling than you do swimming, because of the work of bringing blood back against gravity to your heart, and all of that gets distorted. They have high sympathetic tone, and begins, if one of the things that if you've ever heard Lee Kaplan speak, he always talks about how exercise is not a way to lose weight, but it's the only way to maintain weight loss. And that's because our obese people always have a high sympathetic tone. So we, by accident, began to do some exercise or cardiopulmonary exercise testing on what people who had been labeled metabolically healthy, not on medication, non-diabetic patients that had no cardiac risk factors, because nobody really wanted us to do VO2 max testing on anybody who had any risk factors, and had what they described as reasonable exercise threshold. So basically, the best of the patients that we see, the ones we don't think are sick, and this is what we found. So what CPET testing does is you basically go into a mask and you breathe in oxygen, you breathe out CO2, and it measures that. And you can take the ratio of carbon dioxide to oxygen, and the higher that is, so for example, when that ratio is about 0.6, you're predominantly burning all fat. When that ratio goes up to 1, you're burning more carbohydrate, because that's the lactic acid that's produced from burning CO2. And what did we find in this guy? Well, his metabolic rate's exactly what's predicted, but even at rest, he's burning nothing but carbohydrate. So 100% carbohydrate, you can see that in the green line up top, that's the carbohydrate. The bottom line is the fat that he's burning, and that's, looking at his heart rate across, because this is a resting metabolic rate. So we go ahead and now we exercise test him, because we tell our patients to go exercise. And you can see that bottom green line, that's the amount of fat that he burns. Very early, you see those two bottom lines cross at the top, and that's all of the fat that he's burning when he's exercising. So the maximum amount of fat that he burns in exercise is 3.9 kcal per minute. To give you an idea, a healthy person should be burning at least 10 kcal per minute when they're exercising at peak. What's even more important is he stops burning any fat at a heart rate of 115. So if you have high sympathetic tone, it means going up these stairs is going to get your heart rate to 115. So what do you think happens when he goes to the exercise and does high intensity training? He burns his glycogen stores, it's inefficient, and there's a lock put on his fat. Same thing, this is an obese female, she's slightly heavier. At rest, she does a little bit better, 50-50. But it tells you why you have to look at these people both at rest and with exercise, because when we go ahead and we exercise test her, her fat max, the maximum amount of fat that she's burning is at a heart rate of 80, okay? A heart rate of 80. When she goes up to a heart rate of 102, which is probably just breathing and somebody saying boo, she stops burning fat completely. And her VO2 max is depressed, and she doesn't use fat virtually at all, and her fat max is 3.6 kcal. So she can walk from here to Perth and not burn any fat. Or maybe she'd actually start restoring her zone 2 at that point in time. And I can show you the same thing here. Somebody, 2010, metabolic rate of only 43%, so this would be low muscle patient, and this patient crosses over at 103. And when you look at a healthy male, okay, this is a healthy male, low BMI, exercises regularly. At rest, they're burning 90% fat and 10% carbohydrate. Metabolic rate in the 58th percentile, showing higher exercise threshold. And, again, his crossover is at 142 beats per minute. Now, this is a picture of me up top and one of my dietitians on the bottom, and you can see that the yellow shows you I'm burning fat, and this comes from trying to run every single day out to a heart rate of about 145 to 150. And you can see at the end of my VO2 max, I just start burning completely carbohydrate, but you're burning fat. And what this basically means is the target is our patients kind of lose what's called zone 2 in exercise. And how surgery affects that, I don't know the answer to that. Hopefully we can raise some money and begin to look at that. So when we began to realize this, we wanted to try to understand what's going on. And what is it in the Western diet? We just had Henrietta speak, and what's fascinating, and everybody in Australia knows the story, and it's the same story that's true of Bedouins in Israel or any kind of indigenous people that have been absorbed into the Western culture is that their diabetes rates within one generation go up to ridiculous levels. You're seeing this in the Middle East where they actually import most of their food from Australia, that adult diabetes rates can approach 50 to 60%. And somebody in Australia did a study where they returned the Aborigines back to their native environment and their diabetes went away. So we know it's something in the Western diet, and it probably relates to the mixture of salt and fructose being put into the diet in ridiculous amounts. And there's a huge evolutionary story about this. So again, essentially, fructose and glucose are both 6-chain sugars, but they have very different effects. In today's generation, fructose is considered the evil twin, but that's probably not completely true. Fructose had a very important point. It basically told us when apes moved from Africa to Europe, actually, and there was cold, they evolved a certain metabolic change where they produced uric acid, and fructose allowed them to store fat in order to bear the winter. So just from an evolutionary perspective, actually, humans evolved from Africa, the apes then went to Europe, the apes that survived actually migrated back to Africa, and that's where most of us, that's where modern man descends from. And the ability to have an enzyme called hexokinase and fructose hexokinase, and fructose as a signal when the world became cold so that you could store fat became very, very beneficial. And why that's important is that fructose 6-hexokinase, when fructose is in high levels and goes to the liver, what happens is instead of it being a nutrient, it actually causes the breakdown of ATP to AMP, causing the formation of citric and uric acid. And that begins to explain the links between uric acid, hypertension. And when glucose is in high supply, glucose is shunted to form fructose, and that begins to explain some of the things that our medical colleagues are seeing clinically, like with the SGPLT inhibitors having an advantage for hypertension, metabolic disease, and a survival expense. So obviously the westernization of the diet has a lot to do with this going on, and in what was usually an adaptive response has become a maladaptive response. So people hear me say that and they say, well, stop eating fruit. Yes, there's fructose in fruit, but there's also fiber. What it probably does mean is stop drinking fruit juice, but I think fruits and vegetables are extremely healthy food. But what we really have to realize is what's happened to our patients that we see is that they're overfed, but they're undernourished. They don't have increased muscle mass, and that's really a very, very important point. So again, we wanted to try to understand, if fructose and sugar are really, really important, then maybe we could use continuous glucose monitors as a possible way to treat obesity. But it's really, really interesting, and this really comes into somewhat of the carbohydrate debate, fructose actually doesn't raise CGM. Additionally, this began to show us what's really, really happening. So this was a study that was sponsored by Medtronic where we had 25 adults, all non-diabetic, some who were obese and some who were non-obese, and we did continuous glucose monitoring on them. And, our expectation, we were hoping, is that this could be like a dietary Fitbit. But what we found is exactly the opposite. We found that what happens is the insulin rate, the insulin level fasting, as well as HOMA, which is insulin and fasting glucose divided by a constant, correlates completely with the BMI. But when we look at glucose spikes, either by looking at mean amplitude or mean glucose or the maximum glucose excursion or the standard deviation, there's no difference. And I think this is really a very, very important message for primary care doctors, is that we see fasting insulin elevations and HOMA elevated in our obese patients, but we see no difference in glucose variability. And what has happened is ever since Banting has discovered insulin and kept people alive for years and years, we have looked at insulin as being a glucose regulatory hormone. But the truth of the matter is that insulin is one of its most important roles is basically putting a lock and regulating your fat. So what's happening is we're developing hyperinsulinemia, and clinically we're using the glucose level as a marker for it. And what's going on in the background is secondary to high insulin. That's why we're seeing PCOS in such high levels, because the testosterone is not converted to estrogen. And that's why we see ectopic fat, because the hyperinsulinemia, which comes first, is driving fat. And it's very common that I see patients, and we began to look at this, where we see fasting insulin levels of 75, but hemoglobin A1Cs of 5.2. So the earliest sign that you're going to see of young people is going to see an elevated insulin level secondary to glucose tolerance. And that's where we need to start treating people if we want to try to avoid these things. So it brings into question all of the patients that we thought were metabolically healthy, because what happens is they develop a high insulin level, or at least 80% of them, and the others I've yet to understand nearly as well, and we're using glucose as a background. Meanwhile, that hyperinsulinemia is driving all of the things that you're seeing in the background. So this is a 16-year-old girl that we operated on, whose hemoglobin A1C is 5.8, her LFT is a normal, and this is a 16-year-old liver, et cetera, that you're seeing. So the earliest stages that you're seeing is this hyperinsulinemia that's going up. So really what this takes us is really kind of an interesting thing. When I mentioned the word, when you see patients like I started in my video today, people say, well, he should have eaten better. We should have given him a better diet and things like that. And there's this kind of idea that cancer is just random shit, bad luck, and, obesity is your fault. Yet, I think that they're very, very marked. This is one of my favorite things. Is I was asked to give a bunch of talks about women's health recently, and, just something popped up. The state of Louisiana has the 4th highest death rate of cancer. You know what the state of Louisiana's obesity rate is? 4th in the United States. And it made me look at every single place the obesity curve and the death rate from cancer can basically be superimposed all over the world. So again, as I grew up, Watson and Crick, and actually one of the places we're collaborating with is Cold Spring Harbor, where Watson has done his latest work and trying to do some of the stuff in the future, developed DNA, and we began to think of cancer as related to genetic mutation, and we forgot about the metabolic impact of cancer. And it's interesting, if you go back to World War II, there was a Jewish gay investigator named Otto Warburg who became very controversial. And because he was controversial and spared by the Nazis, much of his science, he was also a difficult personality. He did win a Nobel Prize, but a lot of the things that he said later in his career were put on the side. But one thing that he said has actually rung true, and most of us really grew up not actually understanding it. It's just like the patients that I showed you that preferentially burn carbohydrate. Cancer preferentially burn carbohydrate, and that's called the Warburg effect. So most of our epithelial cancers, what they do is they love glucose. Now, there may be a role in the future of combining diet with chemotherapy as we understand the metabolic roles, but you really can't starve a tumor at the present time. But the Warburg effect has really been absolutely true and been forgotten. And it's interesting, and the question becomes, and we're beginning to look at this with Raoul Mostalsky at Harvard, whether the metabolic switch that's turned on in our patients is the same metabolic switch that gets turned on in cancer. And it's kind of interesting that we've done better treating cancer than ever before, but the cancer that's growing in death rates the highest is actually the poorly differentiated uterine cancers, and they're probably related to high insulin levels. And women who have class 3 obesity have a 62% greater chance of dying of cancer than do people who are of normal weight. Now, why that's happening probably, has to do with hyperinsulinemia, and through the PI3 receptor mechanism, and insulin itself is probably driving growth, and insulin-derived growth factor. There's a lot of similarities between obesity and cancer. The definition of obesity is excess adiposity. It's a disease of overnutrition. Same thing is true of cancer. What happens when we see patients with hyperinsulinemia, they have ectopic fat in places like the muscle, brain, and liver. Same thing similar to metastases. So the question remains is, obesity just a spark and insulin just driving growth of tumors. And it's really interesting. We take a step back, and again, I said we think of cancer as random luck, but how many people do you know have died of muscle cancer or cardiac cancer? Why are cancers of the colon so much more common than cancers of the small bowel? We know that the small bowel turns over much more rapidly. So we're entering the stage where metabolism, we're going to view cancer more as a metabolic disease. The cure won't be as simple as doing a sleeve gastrectomy, but metabolic impacts will have a very big stay in what's going on. And what you see is a convergence of all the chronic type of conditions that we're treating. So, going on more, I think similar mechanisms and the link between obesity and Alzheimer's disease and premature Alzheimer's disease is certainly there. And a lot of people think that that has to do some degree with the difference of glucose regulation in the brain. So as we go forward in this meeting, I think one of the greatest challenges for us is how we can get people to lose weight without losing lean muscle mass and losing bone. It's a side effect, even if we look at really the great Wegovy data, and as we entered into the pharmaceutical age that showed 16% weight loss, and I will say that's really on a smaller subset than what we see in surgery, those patients also lost 13% of their muscle mass. So I think that what I've tried to do today is try to tell you a different story and have you think, because it's kind of ironic. We grew up thinking that fat caused obesity and fatty liver. We find out it's more carbohydrate. What's really, really fascinating is as our diets changed, the best treatment for obesity has probably been to make our GI tract less efficient. Obesity is defined as excess adiposity, but probably the primary defect is fuel partitioning and the inability to burn fat. Obesity can't be the whole story because females have a higher rate of obesity and a longer life expectancy. And what I will say is by the time the conventional labs that we follow are elevated, many people have already lost the gain through the consequences of hyperinsulinemia. And what's also remarkable is that exercise is the only way to maintain weight loss, but it may not be a great weight loss thing in itself. And my explanation is that as you lose weight, your sympathetic tone goes down, so it's really, really important to make believe you're being chased by a saber-toothed tiger. So this is a picture of Dr. Roslin, founder of the Roslin Clinic, who kind of, created the management of diabetes in the United States. And about 100 years ago, he said that if diabetes was an infectious disease, people would really care more. So what we've now seen is we've come full circle. We've seen how systemic our body is and how these impacts are, and that what we're really treating is accelerated aging, and that becomes relevant to everybody else. So with that, I'll conclude and just thank my family, and thank you for having me.